and welcome to COVID-19, Keeping Up with the Moving Target. I'm your moderator, Faith Rogers with BKB Med. Thank you so much for joining us. Here you'll notice several windows on the console. We do encourage you to move these to your liking and minimize what you don't need. There is a group chat available to communicate with the other viewers if you are interested. You're also able to submit questions for the faculty by clicking the Q&A button to the left of the slide window. Questions will be addressed during our Q&A session at the end of the presentation. At the conclusion of the presentation, you'll be able to access the evaluation and a test for credit by clicking the Claim Credit button. Your thoughts and comments are important and will help us develop CME activities on this and similar topics in the future. We'd also like to welcome our Facebook viewers today. Matt will be moderating the Facebook chat, so please ask your questions in the chat for us to direct to faculty. He will also post a link to claim credit. We are pleased to welcome today two expert faculty members, Dr. Michael Angarone, Associate Professor in the Division of Infectious Diseases at Northwestern University's Feinberg School of Medicine. And also joining us is Dr. Chuck. Hi, Dr. Angarone. And joining us also is Dr. Chuck Vega, Health Sciences Clinical Professor at UC Irvine, Department of Family Medicine. Dr. Vega, thank you for joining.
It's absolutely my pleasure.
Here are our faculty's disclosures. And this educational activity is supported by an independent educational grant from Regeneron Pharmaceuticals Incorporated, Eli Lilly and Company, and Gilead Sciences Incorporated. All activity content and materials have been developed solely by the planning committee members and faculty presenters. The learning objectives, please note that the material presented in this program is current as of today, May 19th. For the most up-to-date guidance, if you're watching on demand, please do review the NIH and IDSA treatment guidelines. Today's learning objectives are to appraise the efficacy, safety, and indications for treatments for patients with COVID requiring hospitalization, to evaluate management strategies for outpatients with mild to moderate COVID-19, explain the mechanisms of action of monoclonal antibodies and other current and in development treatments, and describe best practices for managing patients with COVID-19 with monoclonal antibodies and other agents. We have a few knowledge questions to kick off our webinar. If you don't see the submit button, please scroll down as it is sometimes cut off on smaller screens. Let's start with our first pretest question. A 32-year-old man with type 2 diabetes and a BMI of 37 has mild COVID-19 with onset of symptoms 4 days ago. Which of the following treatments are appropriate for this patient? Is it dexamethasone, bamlanivimab, casirivimab and endemab, or bamlanivimab and dexamethasone? Please select your answer. Okay, and the next question is, monoclonal antibody products are authorized to treat which group of patients with confirmed COVID-19? Is that any patient, any non-hospitalized patient 18 years of age or older, non-hospitalized patients 12 years of age or older at high risk for severe disease, and patients hospitalized for COVID-19 12 years of age or greater requiring oxygen support? Okay, and our next question is, according to the Act 1 pivotal trial, which group of patients benefited the most from Remdessevere? Was it all patients benefited equally, patients not receiving oxygen, patients on oxygen not requiring mechanical ventilation or ECMO, or patients receiving mechanical ventilation or ECMO? Okay, and our final question. The Act 1 trial found that intravenous Remdessevere compared to placebo shortened duration by a median duration of, was it 2 days, 5 days, 7 days, or 10 days? Okay, thank you. And again, we will revisit these questions at the end of the webinar. I will now turn the presentation over to our faculty. So Dr. Vega, thank you again for your time.
Oh yeah, it's my pleasure. And thank you for the great introduction, Faith. And I may ask you to pinch hit for me when it comes to pronouncing some of those monoclonal antibodies. You know, we all love that, especially in front of people. This is a great opportunity to talk about COVID-19. We're seeing a big change in the pandemic in the United States. We're seeing a change in the way we're responding to it. But one thing became clear, and Michael and I were actually discussing this a little bit, just how, you know, we look back 15 months ago and pretty much every patient that I was seeing with COVID-19 was going into the hospital because we didn't know what we were dealing with. It was tremendously scary. We were worried about, you know, not just that individual patient, but also the public health consequences of having these cases. We weren't sure how far spread this infection would go, and it became a pandemic. You know, really sad. As we grew more experienced with this illness, we found that most patients, in fact, about 4 out of 5 could be managed as outpatients. They have more mild to moderate illness, and that's really been where I've done the most of my work. You know, in my regular clinic, we also had special post-COVID clinics set up, and so we were busy taking care of patients who didn't need to enter the hospital in the first place, but also post-hospital follow-up patients as well. So I think it is something to bear in mind that most patients are managed in this outpatient sector. And this is a really nice graphic that I think ties together the virology of COVID-19 as well as the symptomatology. And then finally, it even includes where therapeutics are considered to be most useful. So you can see that, unfortunately, that concentration of SARS-CoV-2 rises and becomes highest right before symptoms develop, which is so insidious in the way this infection can spread that you get a lot of spread from people who are pre-symptomatic or asymptomatic. But then in that first week, there's the fever, cough, myalgia. I've seen a lot of different cases of COVID-19 now, and certainly there is no one template. You see one case and you've seen one case, but we've always been concerned about folks doing worse in the second week, where they get that severe inflammation, that cytokine storm can develop, leading to a lot of respiratory distress, and that's what puts people in the hospital. When it comes to therapeutics, it's really ideal to start our antiviral agents as soon as possible. Just like any infection, the sooner you get it on board, the more likely it is to work, certainly with antivirals. And convalescent plasma can be considered in that same range as well. Where we see the application of our immunomodulator drugs is more when inflammation really sets in, particularly that outsized inflammation we get after the initial period of infection, where patients might be doing okay and might be resting comfortably at home before they develop that cytokine storm and severe inflammation develops. So what are the risk factors for severe illness? This is something I'm always calculating and something that's constantly changing as well. As we get more information about COVID-19, the risk factors have changed. I'm not going to call out all of the factors that are on this busy slide, but I will say that in a meta-analysis, COPD stood out as one of the factors that was associated with the highest risk comparatively compared with other major risk factors. Also, more has come out lately on diabetes as a major risk factor. Now it's established both type 1 and type 2 diabetes are both significant risk factors. Obesity is a significant risk factor for severe COVID-19 as well. And you would think that if you have somebody with obesity and type 2 diabetes, those would be additive. Because that's certainly something we see. The more of these risk factors you have, and I have a lot of patients with chronic kidney disease and COPD and obesity and diabetes, the higher your risk goes. They're generally synergistic, unfortunately, in promoting worse disease. But with obesity and diabetes, there was a study that showed that they were actually quite separate and they weren't synergistic, which is, you know, at least one good thing. And this information is always evolving, and so therefore it's something I take into perspective. And so when I'm seeing a patient, I'm accounting for these factors and not just that, the accumulation of factors. And that's going to make my decision as to, you know, whether they might qualify for monoclonal antibody treatment, and also sometimes whether they should be going to the emergency room or being admitted to the hospital directly. One other major risk factor that I can't ignore is the fact that this pandemic has greatly affected Latinx, Black communities, and American Indian Alaska Native communities far worse, both in terms of the incidence of COVID-19 and severity for hospitalizations and even mortality. I think it deserves special attention for providers who see a lot of these patients and they know the toll it's taken in these communities. And I think that right now the imperative is to get as much vaccination to communities of color in the United States as is possible. That will be the best way to fight this infection and this pandemic moving forward. Let's talk about a case just to frame this up for ourselves. Mr. Beals is 52 years old. He's a male. He's presenting to your clinic. He has hypertension. He's also an active smoker, 30-pack year history. He has had myalgia and cough for 24 hours. So you test for COVID-19, and it's positive by RT-PCR testing. So, Michael, I guess the question now is, what can you offer this guy? Seems like he has some risk factors because he's over 50. He's got hypertension and a smoker. What do you think?
Yeah, so this is a great question, Chuck, because this is what we want. We want patients who are going to present fairly early, outpatient, mild disease, and prevent them from getting sicker and potentially prevent them from spreading the infection. And you're going to talk about in a minute some of those treatments that we have in the outpatient. And a lot of what we focused on are people with risk factors, especially risk factors that put them at high risk for developing severe COVID. And he has some of those. The smoking obviously is something that we worry about, the hypertension. Does he have COPD from the smoking? And I know you're going to talk to us more detail about the treatments, but this is the type of patient that you would want to assess and want to try to get treatment as soon as possible if he's in the outpatient setting to try to get him treated.
And we know that monoclonal antibodies are effective. I'll speak to that in a minute. I think the difficulty in applying these agents has been in the logistics of getting them on board, of finding a center where you can do infusions, where they can monitor patients for severe reactions, because that has to be part of the protocol. It's very important. And as we've gotten more experience, I think we've really streamlined those logistics quite a lot. In terms of his characteristics, he's on the borderline of qualifying, but use your judgment. I think that I find that sometimes I've had a few patients where they didn't meet that one single characteristic that that said they should be sent for monoclonal antibodies, but they had several characteristics that were very close. And so therefore, use your judgment. How are they showing up early in the course of disease versus day 9 or day 8? And what's their accumulated risk? Look at the whole patient in front of you. And I think that's been something of a guide. Whereas I usually find I stick to what our protocols are. Sometimes I made an argument for a case where it's just like, gosh, this seems like a person who would really benefit. And I think that that's been to the patient's benefit as well, to do that advocacy. So let's think about treatments, and we'll focus on the ambulatory patients. So no matter what this gentleman gets at the end of the day, we're going to do close monitoring of his symptoms, having a reliable thermometer at home, emphasis on reliable, and emphasis on thermometer, because I've been surprised how many households don't have thermometers these days. Makes it very difficult to clear somebody when they say, yeah, I had like these chills yesterday, but I'm on day 11 after my onset of symptoms, so can I break isolation? And it's like, so you really want to get objective measurements. And pulse oximetry at first was really hard to get because they were gone. There was just no supply last summer. And now we're seeing that these agents the pulse oximeters are much more available. So you really want those tools on hand. I'm a big believer in supportive care. There was a scare about use of NSAIDs among individuals with COVID-19, that their infection may grow worse on it. That really has not been proven to be the case at all. So therefore, and it's one of the things you can do. People are really suffering with this illness. So, antipyretics, analgesics, it's one of the least things you can do. So go ahead and use those. And we're probably all familiar with the rules for isolation and quarantine, and just try to stick to those as much as possible, and put the person who is, if you have to have one caregiver for a COVID-19 patient isolating at home, make sure it's the one that has the least risk for complications of COVID-19. Maybe they already had the infection, which has happened more and more. There's always somebody around who's actually had COVID-19 in the past, or been vaccinated and is not, older and more frail. So that's just advice I give to patients as well. But there is another way. Using these antibody-based therapies really has proven effective and has some real outcomes that support their use. And the best way to think of these agents is think of them as antivirals. As Michael said, the earlier you get them on board, the more effective you can expect them to be. And so the first one I'm going to talk about is bamlanivimab plus etesevimab. And this is a cocktail of 2 different monoclonal antibodies. All of the antibodies are directed at the same SARS-CoV-2 spike protein, but they target different antigens, different epitopes on that protein, and therefore they could be synergistic when combined together. And so here we have two, and this got its emergency use authorization in February. Now, bamlanivimab as monotherapy got its emergency use authorization for COVID-19 in November. And what happened to that? Well, don't worry, I'll get there, but we don't give bamlanivimab as monotherapy anymore. This has really replaced it on the market. And it's based on results from the BLAZE-1 trial. BLAZE was designed originally with an outcome of a virologic outcome. Who could clear SARS-CoV-2 at day 11, placebo or these monoclonal antibodies, which one was faster? And there really wasn't much of a difference, particularly with bamlanivimab monotherapy. And that wasn't necessarily the best target either, because patients with more mild to moderate illness are more likely to clear SARS-CoV-2 by day 11. What they did find that was consistent across BLAZE was that there was a reduction in healthcare use. So there was a reduction in ED visits, reduction in hospitalizations associated with monoclonal antibody therapy. And that's a very patient-centered outcome. That really matters, particularly when we were trying to be good stewards of our healthcare resources and keep as many patients as possible out of the ED and out of the ICU. It also, if you look at the study, the characteristics of patients in the study, and more diverse in terms of race and ethnicity, a younger age group overall, and many with a risk factor, even patients with more mild to moderate illness. The majority in our practice in downtown Santa Ana have more than one risk factor for complicated COVID-19. So this is really, it's effective among more mild to moderate illness as outpatients among those patients at higher risk for complications. This is another study looking at BLAZE, and now we're looking at hospitalizations or death. And you can see that the high-risk patients in particular had the best benefit. So it's the ones who are at the highest risk for complications. Those are the ones who do the best on bamlanivimab plus etesevimab. And this was a lower dose. Lower dose was proven to be effective and pharmacologically kind of similar to a higher dose. And so when they did their dose finding studies, this is the one they settled on overall, the 700 and 1400 milligrams. Let's talk about the other monoclonal antibody that also has an EUA. This is Cassava Map plus Endemab. And so it was approved for the EUA based on a fairly large trial. Again, younger age group, diverse patient population, most individuals with a risk factor for complications, obesity being the most common. And again, a significant reduction in healthcare use. So medical visits through day 29 were improved. It makes sense that not only high-risk patients get more benefit from monoclonal antibodies, but those who don't form a good immune response, so those who don't form their own antibodies, get more benefit from monoclonal antibodies. Overall, these infusions are associated with a rate of adverse events that are similar to placebo. They do require IV infusions. The IV infusions last an hour, and then they have to be patients have to be monitored for at least an hour afterwards for any severe adverse reaction. That was something I was really concerned with when the EUAs come out. When the EUA's reports came out, there were about 1,000 patients they had in the safety protocol looking at those severe adverse reactions. And there were 4 cases in those 1,000 patients, one of which required epinephrine, all of which resolved very well without any major complications to the patient. So it seems like they're extremely rare. And as monoclonal antibodies have been used progressively more around the United States, I just haven't seen any safety signals that there was some, untoward or unheard of previous complications. These agents are very safe. Still, patients should be monitored for an hour after the infusion, and there has to be a crash cart available and people who know how to use it at the same time. And that's some of the logistics that's hampered the application of monoclonal antibodies. But Cassava Map plus Endemab also has newer data, a very much larger trial, 4,500 individuals. They're all at high risk for complications. And not only was there reduction in hospitalization or death in this cohort associated with the monoclonal antibody treatment, but there was also a reduction in symptoms. And so in this study, the review group that was monitoring the study decided to end it early because there was a clear advantage for Cassava Map plus Endemab. So what happened to bamlanivimab? This is what happened to bamlanivimab, is that the rise of certain variants has made it untenable as a treatment for even mild to moderate COVID-19. So the B117 variant, which is also known as the UK variant, that one is still sensitive to bamlanivimab. Really, it is also the predominant variant in the United States right now. But all of these other emerging variants that contain this S484 mutation, such as the B1351, the P1, and here in California, the B1429, all have a significant resistance to bamlanivimab as monotherapy. Combine bamlanivimab plus etesevimab, though, and you see a mild but not a clinically significant reduction in efficacy of bamlanivimab plus etesevimab. So therefore, the combination still counts. Casirivimab plus endemab has yet to be touched by any of these variants, yet there is still continuing data coming out. And so we don't know what's next. And so this is something to bear in mind. Luckily, NIH and IDSA are watching the situation, and they give us feedback as to which ones, which monoclonal antibodies might be preferred in a given situation. Right now, either are fine. And the key is, I don't quibble too much as to which monoclonal antibody cocktail they're going to get. The best one for a patient is the one they can get right now. So I really want to get patients ideally within 48 hours, and I've done it a number of times. I feel very proud of myself that I did it. But I'm also proud of our patients, and I'm really proud of the teamwork that took across our institution to get those patients treatment that quickly. And I felt a lot better about their chances. It starts with following the guidelines on the EUA. And so really these agents are just for age 12 and above. And they're for patients at high risk of COVID-19. And it's only for outpatients. It's not for inpatients. As I said, you have to monitor the patients during the infusion and afterwards, and have an emergency equipment available, essentially. This is the complicated criteria for those monoclonal antibodies. If you think back to Mr. Beals, did he meet all these criteria? Well, he's 52 and he does have hypertension, but he's not 55 and has hypertension. He's a smoker, but we don't know if he has COPD or not. And so he's really he's on the fence to me, because he has characteristics which would make me think of using monoclonal antibodies, but he doesn't necessarily fit all the criteria. You may be asking yourself, gee, what adolescents might need monoclonal antibodies down to age 12? Well, any child with obesity is one, and the other major factor is asthma. So those are two common conditions I see in our adolescents, and I'm sure adolescents nationwide. And those conditions by themselves in a 12 to 17-year-old should get them consideration for monoclonal antibodies. So you want to use them as an antiviral, get them on board as soon as possible. They are not for hospitalized patients. And here are the NIH and IDSA recommendations that I alluded to earlier, that really NIH says either cocktail is okay. IDSA says that as well, but also we have to continue to watch the response to these variants. And just remember, the more patients who get vaccinated, the less transmission of COVID-19 there is overall, drives the rate of variants down. I'm sure we're all aware of that, and something we preach every day. You may be thinking to yourself, because you're clever, gosh, we use antivirals as treatment, say, for influenza, but we also use them as prophylaxis against influenza as well. Is there a potential role for monoclonal antibodies as prophylaxis? And there is actually some research to support that. With bamlanivimab, was tested in skilled and assisted living facilities, skilled nursing facilities in particular. And what they found was that it was effective as monotherapy in the prevention of transmission of COVID-19, both to residents and to staff as well. And these assisted living facilities obviously impacted, much greater than any other type of living arrangement in terms of mortality associated with COVID-19. So that is important, and it's a space to watch. With casirivimab plus endemab, it was demonstrated to reduce household transmission of COVID-19, another important space to watch. Also, check out the way it was administered. It was not an IV infusion, it was administered subcutaneously. The more we can simplify the application of these monoclonal antibodies, I think there's going to be better uptake, because they are effective and they're well tolerated. All right, let's go back to Mr. Beals for a second. So he has a telehealth appointment with you 2 days after he declined monoclonal antibody infusion. What? After all that presentation, he still said no. But yeah, that's how it goes sometimes. He's on the fence for those criteria. So let's see how he does. Oops, he developed fever and dyspnea. They are worse today. That's no good. He goes to our triage center where they report the following vital signs: his temp's 39, blood pressure high 156/92, pulse 106, respiration 16, but his pulse ox is 99% of room air. So Michael, I'll pitch it back to you again. What do you think are next steps for him besides rechecking that pulse ox once or twice more?
Yeah, I think now with this pulse ox and the tachycardia, and just the fact that he's had this infection for a little bit and seems to be getting worse with the dyspnea, he really needs to be watched closely and he needs to be admitted. I think this would be someone that, everyone would be really uncomfortable just watching at home at this point in time, because I think he's demonstrated that he's getting worse and he may continue to get worse, as I think you pointed out with your graphic early on in the presentation about this kind of biphasic or bimodal illness that we see with coronavirus infection. And so I would definitely admit this patient to the hospital just for more treatment. And this is where we have actually, I think, a little bit more benefit in treatment for our patients, or at least a little bit more in our armamentarium. Anything you would specifically do being his outpatient doc for him, Chuck?
No, I absolutely agree with you, and I think it's not just a chance to monitor him and feel more safe if he needed oxygen support, if he needed intubation eventually, that could be offered much more readily, obviously, in the hospital versus the home. But the fact is, he's moving to a place now where I can see that he could benefit from additional treatments, which we also know are effective, and now we can intervene, and we know that some of these treatments actually prevent mortality. And so I think that's exactly where I go. So it's time to hand off to you, Michael, and put him in the hospital.
All right. So now we'll move into talking about the management of hospitalized patients. So Mr. Beals, our patient, has kind of demonstrated that he's has a need for being hospitalized. And this is what, as Chuck pointed out, about 10-15% of the patients that we're seeing with coronavirus infection are in need of. And luckily, we have a little bit more tools in our armamentarium for helping patients out who get hospitalized. And the first approach that we have are the antivirals. So yes, we have the monoclonal antibodies, which act like antivirals in that they bind up the virus and help get rid of the virus. But we also have direct-acting antivirals. And the major one that we have, and right now the only one that's FDA approved, is Remdessevere. Remdessevere is a drug that was actually developed for SARS-1, MERS, Ebola, and it works by inhibiting RNA replication, therefore lowering the amount of total virus that's out in the system that can infect more cells, cause more of an inflammatory response. And so what's the data for Remdessevere? So probably the largest data set that we have comes from the NIH adaptive COVID treatment trial and the part 1, so the Act 1 trial. This trial was a blinded randomized controlled trial that enrolled about 1,000 patients that were randomized to either Remdessevere or to placebo. So we have the benefit of kind of placebo or usual care for coronavirus early in the pandemic. Most of the patients had symptoms for around 9 days. The primary endpoint was time to recovery. The median time to recovery in the Remdessevere arm was 10 days versus 15 days in the placebo arm. This was statistically significant benefit in time to improvement and time to recovery for Remdessevere. There was a trend towards a mortality benefit. At day 15, the mortality was 6.7% in Remdessevere, 11.9% in placebo. By day 29, which was the end point of the study, Remdessevere mortality was 11.4%, placebo was 15.2%. So numerically better, but not statistically better, although close. When we look at just graphically, we could see in the entire population there was benefit in Remdessevere for that cumulative recovery compared to placebo. This really demonstrated benefits in our patients who were receiving oxygen. So our patient, Mr. Beals, He has a low pulse ox of 90%. If we repeated that, it was still 90, 91%, and he required oxygen, he would benefit from Remdessevere at this point in time. Unfortunately, our patients who progressed a little bit further to needing mechanical ventilation or other more advanced supportive measures didn't fare as well with Remdessevere versus placebo, and there was really no benefit. And this was somewhat of a disappointment early in the pandemic because that's what we were worried about with those very sick individuals. Adverse events were pretty similar between the Remdessevere and placebo, and those adverse events were changes in GFR or creatinine, changes in hemoglobin and lymphocyte, respiratory failure, fevers, hyperglycemia, a lot of the symptoms of just progressive coronavirus. So it's really hard to know were they adverse events or were they related to progression of the disease. More severe adverse events, the grade 3 and 4, again, were very similar between Remdessevere and placebo. We also now have some kind of non-clinical trial. I think the kind of parlance that we use is the real world data instead of the controlled trial data for Remdessevere. This is a retrospective comparative analysis that looked at, in a single center, that looked at around 2,400 patients who were admitted. They chose about 285 patients who received Remdessevere, compared them to 285 controls. A very diverse population. So about 21% were white, 33% Black, 34% Latinx. So similar to what a lot of us are seeing in our hospital centers, and even more diverse than some of the clinical trials that have been done in terms of randomized clinical trials. The time to clinical improvement was 5 days for Remdessevere versus 7 days for placebo. This was statistically significant. So again, demonstrating improvement in clinical symptoms in the Remdessevere versus placebo. Mortality was 6% versus 13%. Again, not statistically significant, but numerically lower for Remdessevere. When individuals were looked at that received steroids, there was a longer time to improvement and similar 28-day mortality. So a little bit different than what we've seen with dexamethasone itself, which we'll talk about in a few minutes. And when we look just graphically here, patients with severe disease, there was a benefit. Patients with mild to moderate disease, there was a benefit. And then looking at the criteria for the Act 1, there was a benefit. So again, you can see that there was consistency between Act 1 and this kind of real world experience with Remdessevere. So the NIH and the IDSA both recommend Remdessevere, especially in patients, or specifically in patients who are hypoxic with low oxygen saturation, so less than 94%, requiring supplemental oxygen. The NIH recommends using Remdessevere through mechanical ventilation or ECMO, whereas the IDSA recommends that you can use it for people on mechanical ventilation or ECMO. So that's a little bit of a difference between the two recommendations. The next therapy that we have to offer for patients who are admitted to the hospital that is like an antiviral is convalescent plasma. The way that this might work is that it may neutralize the virus, similar to what monoclonal antibodies do. It may control the hyperinflammatory state, similar to IVIG or intravenous immunoglobulin that's used for other infections that we don't have very targeted antiviral therapies for. There may be immune modulation of the hypercoagulable state. And there's also an EUA and a look for high titer plasma in hospitalized patients versus lower titer. Multiple different studies that have been done on convalescent plasma. Very few are direct randomized trials. A lot are individuals getting convalescent plasma and then just looking at different points at which to analyze. This is one study and a targeted group of patients from the Mayo Clinic experience of about 3,000 patients who received convalescent plasma. These patients were all kind of comers. They had about 60% in the ICU, 33% on mechanical ventilation. And specifically what this study looked at was low, medium, and high titer of the neutralizing antibodies in the convalescent plasma. And what they found was that individuals who got high titer had a lower mortality versus those who got low titer. Higher titer recipients had a lower rate of a need for mechanical ventilation versus those that got low titer. And so there was some benefit or hint at benefit for high titer convalescent plasma. This was somewhat mirrored by a randomized trial looking at early plasma for older adults, so looking at those that were 75 years or over. This was a trial of 160 patients that were randomized to either high titer convalescent plasma or placebo. The median age was about 77. The plasma was given within 72 hours of symptom onset, so pretty early in illness. And they specifically looked at a high titer being a median over 3,200. There were some that got a median titer less than 3,200, and they fell into the low titer group. When they looked at this group of patients, of placebo, less than median or higher than median, what this group found was that there was a lower rate of progression of disease to severe respiratory illness in those that received high titer plasma. So about 8% in the high titer plasma versus 31% in the placebo for a 73% relative risk reduction, which was pretty good. But then this brings up, I think, some of the newer data that's brought a lot of pause with the use of convalescent plasma. So this is the recovery trial. Again, the recovery trial, very large trial that's being done in the UK that's randomizing individuals to multiple different therapies and multiple different arms. So a very, I think, well-designed multi-tier trial that's being done. And what this trial looked at were individuals that got convalescent plasma versus usual care. So that's kind of the control group, is just the usual care. In the recovery trial, they found no benefit when it came to all-cause mortality for individuals who received convalescent plasma. They also did a meta-analysis with this trial looking at other studies on convalescent plasma, and again found that there was no benefit to the convalescent plasma. For progression to need for mechanical ventilation, recovery again didn't show any benefit, as well as the meta-analysis for other trials that are out there. And so this really kind of changed our recommendations from earlier last year, so in 2020 and then early in 2021, of the use of convalescent plasma, especially early in hospitalization or early after symptom onset, to really kind of changing our direction and recommending either not having sufficient evidence for or against for the NIH, or the IDSA actually suggesting against the use of convalescent plasma, and really focusing on individuals that are in studies to kind of study the benefit in the outpatient or ambulatory context, to study the benefit in individuals that may have more severe disease. So that's the antivirals. So the next group of therapies that we have are the immune modulators. So these are the therapies that can actually modify the immune response. So as Chuck talked about, that kind of second phase when the virus may not be playing much of a role anymore and the immune system is really taken over. The treatment that we have for these individuals is dexamethasone. This is something that was looked at early in the recovery trial, and it was the hyperinflammatory arm of the recovery trial, and individuals were randomized to dexamethasone or standard of care. And what this trial showed was that for the overall population, there was a mortality benefit. 25% for the usual care, 23% for the dexamethasone. For individuals that were ventilated, there was a mortality benefit from 41% in the usual care to 29% in the dexamethasone. For those on oxygen, there was also a mortality benefit, 26% versus 23%. So the first agent that really had mortality benefit, and that we were really excited to kind of offer our patients who were sick, They were on oxygen, they were ventilated, and they had a therapy that would benefit them. One of the elements of this study that was kind of interesting and again, points towards maybe the virus playing a role more early in the illness is that those individuals not on oxygen actually had higher mortality than the placebo when given dexamethasone. And so it's really not recommended to give dexamethasone to patients that are not on oxygen because of this higher mortality. So the conclusions from the recovery, again, first drug to show mortality benefit on mechanical ventilation or oxygen, really not recommended for individuals on oxygen. Some of the questions about this trial were the fact that there's higher mortality in the recovery than what we generally see in the United States, but that still has had us recommend dexamethasone for patients on oxygen. So if we go back to Mr. Beals, being put on remdesivir, being put on dexamethasone, I think would be very appropriate for him once he's admitted to the hospital. And Mr. Beals indeed does get remdesivir and dexamethasone. Over the next 72 hours, he has worsening hypoxemic respiratory failure. He's transferred to the ICU, started on BiPAP, and he's also noted to having an increasing CRP. And so now, what are the next steps for this individual, for Mr. Beals, given his progressed condition? And this is where a lot of our efforts have really been focused, and I'm sure all of you have seen patients that have progressed in this manner, where we are really looking for what are the next things that we can do. What is it that we can do for this patient who's getting sicker? And we want all the different tools that we have so that we can get this patient through this. Chuck, I know you're primarily in the ambulatory setting, but I'm sure you've had patients that you've taken care of that have advanced or progressed in this manner. And is there anything that you try to talk to families about as patients are getting sicker in these situations?
Yeah, I mean, it's a really difficult and tragic situation because, you know, we're really starting to get to that critical point, and patients and their families are going to be scared. You know, at this point, you know, I'm not engaged in the active treatment decisions, to be honest. I can advise and help, and I would think about an IL-6 receptor inhibitor in this case. As a potential way to improve things. But it's also about maintaining lines of communication and being there, because that's something that that we were doing really poorly, especially at the outset of the pandemic, when we didn't have all our infection control protocols in place, and we weren't sure what we were dealing with. And so patients felt isolated. They felt that the healthcare providers who they saw were not, well, they weren't really seeing them because they were behind these spacesuits. And so therefore, there's a disconnect, and patients were dying alone. Very terrible stuff, particularly for lower income and people of color again. So that's something I pay attention to. And yeah, I certainly want to offer whatever resources I can just for the ongoing support and giving true information to both patient and family through these kind of crises.
Great. Yeah, and I do think that's really important. And we know early in the pandemic that was an issue, communication. But I think you bring up the IL-6 receptor antagonist. And so this is where this patient would fall into the category of someone who would benefit from this. Bunch of studies that were done early on in the pandemic, looking at IL-6 receptor antagonists as monotherapy, a lot of conflicting data, back and forth with benefit, with no benefit, with harm, with not as much harm. And so we were really at a loss as to what to do, and there was not a lot of recommendations for what to do or how to utilize these therapies. Well, now there's two recent large trials that have been presented. The Remap cap was the first one that was presented, looking at the IL-6 receptor antagonist, tocilizumab, sarilumab versus control. And they looked at people that were on high flow oxygen, that were quick in the ICU, but less than a day. Many got dexamethasone, so over 80% did. And the primary endpoint for this study was combined mortality and days free of oxygen support. And what this trial showed was that tocilizumab had a 10-day improvement in organ-free support days compared to placebo, and the mortality was 28% in tocilizumab versus 36% in the control group. Similar outcomes were seen with sarilumab, but the numbers were much smaller. But the tocilizumab showed demonstrated a benefit for mortality as well as organ support-free days. The next study was, again, going back to the recovery. So this large UK trial, this was a specific arm looking at progressive inflammatory disease. So they looked at individuals who were progressing through their illness, who had worsening oxygen saturation, as well as increasing CRPs. And they were randomized to a single dose of tocilizumab or just usual care. And again, what this trial demonstrated was that the 28-day mortality had a 15% decrease in the tocilizumab arm versus the usual care arm. The 28-day to discharge was a 22% increase. So more patients that were being discharged from the hospital who received tocilizumab. And then progression to invasive ventilation, there was a 21% decrease in tocilizumab. And so again, really kind of started to change our thinking of these therapies. This was demonstrated kind of throughout all participants in multiple different arms that were looked at. Interestingly enough, those who did not receive steroids did not fare as well as those who did. And so was it the steroids and the dexamethasone that was offering some benefit? And the recovery trial authors actually did a meta-analysis of all of the IL-6 receptor antagonist studies and actually found that when you add recovery, there is a benefit through this meta-analysis. And this really changed what the NIH and the IDSA were recommending. And they were recommending that tocilizumab and dexamethasone should be given in patients who are transferred to the ICU within 24 hours, require more invasive mechanical ventilation or non-invasive mechanical ventilation, and have rapidly increasing oxygen needs and an elevation in the CRP. And then the IDSA in hospitalized patients with severe or critical COVID and markers of systemic inflammation, they suggest tocilizumab as well. So kind of another therapy for this hyperinflammatory state. And indeed, Mr. Beals would be a candidate for that. So we'll end our case with Mr. Beals. So Mr. Beals is admitted. He received supported care with supplemental oxygen. He received remdesivir, dexamethasone, tocilizumab. He improved over the next 3 days of his hospital stay. He's being discharged home. So Chuck, what considerations do you have for discharge? Because I know this then is where you're going to play, I think, a very important role in what's going on with Mr. Beals.
Yeah, I think it's important to set expectations because, patients may think, well, I'm out of the hospital, I should feel 100% better. And they're not. They're still going to be in this for quite a while, particularly with regards to dyspnea and even hypoxia. So you may require oxygen going home. You should have a pulse oximeter going home. So monitoring for other new signs and symptoms have to be very strict with regards to what his ED precautions are to go back to the emergency department. And it's my job to, help, I think, further those goals by contacting the patient via telehealth. So I'm going to certainly try to set up an appointment within 2 days of discharge. So usually within 48 hours. And again, maybe 48 hours after that, until they really are truly recovered, where my dyspnea is minimal. I don't need my oxygen anymore because I know what my oxygen saturation is. I feel a lot better. Yes, I don't know anybody who's recovered to the point where they go back to normal, whatever normal was for them. But they certainly feel that they're on the road to recovery. Maybe there's some fatigue. Maybe there's some mild shortness of breath. They're not able to do all the stuff they used to do, but they're able to get around their house and do, at least some of their activities of daily living. And that's when you can start spacing these visits out. And it is a struggle. And I think just helping patients understand it's going to be slower recovery for the majority of patients, helps them to just take the little wins they can get every day and make the most of them. A positive attitude helps when it comes to COVID recovery. And with that, I think we can probably get to some of our conclusions now. So monoclonal antibodies, they do work. They reduce healthcare use. But they really are reserved for outpatients. These are your patients with mild to moderate illness, but they are at high risk for progressing to severe disease or hospitalization. They have to be at least 12 years of age. Antiviral treatment with Remdessevere, FDA approved. It is the FDA approved agent against COVID-19, and it is for hospitalized patients. They should be on oxygen, but not requiring mechanical ventilation or ECMO. That's who benefits the most. And remember in Act 1 that the average reduction in symptoms associated with Remdessevere versus placebo was 5 days. The antiviral antibody-based therapies, those are like convalescent plasma, monoclonal antibodies. These are going to work most effectively if they're initiated as soon as possible. And dexamethasone as a drug that's established to lower mortality rates among hospitalized patients. And with that, I'm going to hand it off now to Faith for our post-test, and then we'll get some questions.
Fantastic. Well, thank you so much, Dr. Vega, Dr. Angarone, for that very important information. To our learners, please ask any questions you may have for faculty by submitting them in the Q&A box. But first, let's revisit our knowledge questions. Okay, this says a 32-year-old man with type 2 diabetes and a BMI of 37 has mild COVID with onset of symptoms 4 days ago. Which of the following treatments are appropriate for this patient? Dexamethasone, bamlanivimab, Cassava Map and Endemab, or bamlanivimab and dexamethasone. Just for reference, here's what you said before. And here's what you said after. So would you like to expand on this, Dr. Vega?
I rarely see 100% in anything. So yeah, I hope everybody can see that you got the answer exactly right on your post-test after seeing some variability in the pre-test. But Cassava Map plus Endemab is absolutely right. Bamlanivimab would have been an option several months ago, but due to those emerging variants, it's not offered as monotherapy anymore. But great job. This is a, with the diabetes and the BMI of 37, this is a person who's a good candidate for monoclonal antibodies. The only correct option there is C, Cassava Map plus Endemab.
Excellent. Okay. And our second question is, monoclonal antibody products are authorized to treat which group of patients with confirmed COVID-19? Is it any patient, any non-hospitalized patient greater than 18 years of age, 12 years of age or older at high risk for severe disease, patients hospitalized for COVID-19, 12 years of age or older requiring oxygen support? Give you a moment to answer. For reference, here's what we said before. And here's what we said after. Dr. Vega, what do you think about that? What's our right answer?
The answer is number 3, or C, non-hospitalized patients 12 years of age or older at high risk for severe disease. Monoclonal antibodies were tested among inpatients rather, among hospitalized patients. They weren't effective. There are some ongoing trials, but they should not be used in hospitalized patients outside of those trials.
Perfect. Okay, I'll move along to our next question. According to the COVID Act 1 pivotal trial, which group of patients benefited the most from Remdesivere? Was it all patients benefited equally? Patients not receiving oxygen? Patients on oxygen not requiring mechanical ventilation or ECMO? Or patients receiving mechanical ventilation or ECMO? Okay, and again, here's what you said before. And here's what you said after. So Dr. Angarone, how did we do here? What was the correct answer?
So the correct answer is patients that are on oxygen, not requiring the mechanical ventilation or ECMO. And that is the group that benefited the most. I think in the old speak, it was the ordinal group 5 and 6, if you look at the actual trial. And those not on oxygen did not do as well. So I think it's great that everyone, again, as Chuck mentioned, rare to see 100%. And again, I think a flip from 100% for the incorrect answer to now the 100% correct answer.
Absolutely. Great. And here's our next question. The Act 1 trial found that intravenous Remdesivere compared to placebo shortened illness by a median duration of, was that 2 days, 5 days, 7 days, or 10 days? Give you a moment to answer. That. Dr. Angarone.
Yeah. So again, I think the 5 days is the correct answer when you look at the benefit that is in the Act 1 trial. And again, I'm glad to see that everyone a majority of people actually got the 5 days answer correct. And again, it's looking at that improvement. And when you look at the trial, it's getting people either to be out of the hospital doing okay, or in the hospital and not requiring any further care, which is, I think, really the benefit that we're looking at.
Perfect. Well, thank you so much again to both of you. As a reminder, to submit a question, please click the Q&A button to the left of your slide window. We will try to get to as many as time allows. Our first question is there any value to antibody testing after vaccination? So a patient was negative for antibodies 2 months after their second vaccine.
Yeah, I can try to take that one. So the question is there a benefit to testing for antibodies after a vaccine? I don't think so. Not for the the vast majority of folks who are maybe outside of a research protocol, because the vaccine efficacy was established in solid clinical trials. It's also been confirmed among more population-based studies as we use the vaccines more broadly. I do expect, though, that individuals who have some kind of immunocompromise or just multiple chronic illnesses and they're older may not develop the same immunity that other individuals might have. And that's something that we have to take into account. Certainly just regular precautions for everybody against COVID-19. We continue to use our public health measures as indicated. And it'll be interesting to see how the booster story plays out, because we really don't know where that will be, and if there may be some populations we have to think about boosting earlier than others. There'll be more to come in this area.
Perfect. Thank you so much for that. And our second question here is, I'll toss this one to Dr. Angarone. Can you comment about the use of Remdessevere along with dexamethasone? Is there data to support their use together?
So that's a really interesting question. And if you look at some of the trials, and in particular the recovery trial, there was potentially a slower time to recovery. In the pragmatic trial that I presented, there was a slower time to recovery when given steroids. I think we give Remdessevere to patients early in the hospitalization because it's going to have that antiviral effect. We give the steroids really targeting at the mortality benefit that it has. And so that is why we tend to give it both the Remdessevere and dexamethasone to individuals who are on oxygen who are admitted to the hospital.
Okay, fantastic. The next question is, can individuals who are vaccinated contribute convalescent plasma?
So currently not, because it hasn't been looked at in terms of what type of antibody is specifically being developed, being removed from the body to develop that convalescent plasma. And many blood banks aren't even collecting convalescent plasma anymore due to some of the newer data that's coming out. And so right now, I wouldn't recommend, telling a patient to go who's vaccinated to go donate plasma.
It is an interesting concept, but yeah, I'm also not sure about the concentrations, the type and concentrations of antibody after vaccination versus an acute infection may be different, and that's something to consider as well.
Okay, great. I will ask this again, Dr. Angarone. It looks right up your alley. When should Remdessevere be administered? Is it as soon as the patient is hospitalized?
So it should be if the patient qualifies for getting Remdesivere, if they're hypoxic, if they're potentially going to the ICU, but not, those are the patients that I would target. And I would give it as soon as they're hospitalized if they're hypoxic. So our patient that we used in our example, he was hypoxic at the urgent care. If he was admitted, I would start the Remdesivere right away. If he wasn't hypoxic, I would wait to see how he progressed over the next 24, 48 hours.
Okay, fantastic. I'm going to toss this one up. It could go either way. Can monoclonal antibodies be used in hospitalized patients for a patient in the hospital setting for something besides COVID?
Well, they aren't recommended for hospitalized patients right now, but there are some trials that are looking at this issue. I think one of the principal problems is, when do patients often come in the hospital? Certainly we see patients within 48 hours of the onset of COVID-19 illness who enter the hospital, but many of them come in on day 10 or 12, and it's really more that hyper-inflammatory response that it's an issue, as opposed to the action of the virus itself at that point. And so we can expect that monoclonal antibodies, as we saw in early clinical trials, weren't that effective among inpatients. But there are ongoing trials underway to see if they may be better at a subset of patients maybe who were admitted earlier, for example.
Okay, great. Well, here's our final question. Is there any further information on inhaled Remdesivere that can be used in outpatients or inhaled steroids early with mild symptoms?
I think that's a great question. And the question, when it came up in the inbox chat, was, really, it sounds like we need more treatments early on in the course of illness. And yes, most definitely. And that's what I think a lot of people are working on. Right now, the inhaled Remdesivere is in the very early stages of being evaluated. And so it's not ready for kind of prime time. And I'm sure they're going to start enrolling patients soon to try to see what the benefit is as you get more patients, just like in Act 1 when we had more patients. The inhaled steroid story is somewhat interesting. There has been a couple of studies, again, observational, looking at inhaled steroids. Budesonide, I think, was the big one. And there seems to be a protective benefit. And so we do see a lot of patients being put on inhaled steroids. I don't think that that is inappropriate if a patient is having a little bit of shortness of breath, but they're not sick enough to admit, or they're not hypoxic, there may be some benefit to that. Out of all the other therapies that are being looked at, I think that one has potentially the best promise to show some benefit at keeping people out of the hospital.
Okay, fantastic. And I will add too, I heard budesonide. We're actually on June 9th, Dr. Allwater will be doing a program called In the Pipeline, where he'll just kind of be talking about all of the in development treatments. So everybody keep your eyes peeled for a promotion for that in your inbox. Thank you again, Dr. Angarone and Dr. Vega. For our audience, if you'd like to claim credit, please click the claim credit button that will appear when the webcast ends. Please be on the lookout for a 30-day survey, which you will receive through email. As always, your responses will help us develop further education. We thank you for joining us, and have a great day. Dr. Angarone, Dr. Vega, thank you so much.
Thanks to everybody. Thank you.
Yeah, thanks everyone.